Okay, so new module here on cholesterol lowering agents. This is the first part of the module, and then the second part of the module we start to get into some cardiovascular and antihypertensive medications. So let's start with cholesterol lowering agents. So what's the purpose of this? Well, elevated levels of cholesterol, in particular certain fractions of cholesterol that's carried in the bloodstream, is associated and linked to cardiovascular disease and cerebrovascular disease. So really the intention of these medications of lowering certain parts of cholesterol that's in the bloodstream, and we'll come to the different parts in a minute, is to reduce atherosclerosis, which is plaque formation in arteries throughout the body. So you might be on a cholesterol lowering agent because you have atherosclerosis throughout your entire body in the arteries, or you've had a stroke from like an ischemic stroke, and to reduce atherosclerosis to the cerebrovascular arteries. Commonly, it's following a heart attack or angina, where you're put on these medications to reduce the progression of atherosclerosis. Now, the initial treatment of elevated cholesterol is actually dietary. It's lifestyle changes. So diets that are low in saturated fats. Saturated fats are animal fats, and they often have high levels of cholesterol in them compared to fruits and vegetables, which have extremely low or absent levels of cholesterol. Proper exercise. Exercise actually lowers, well, not only does it keep you healthy, but it does lower overall cholesterol levels. Weight loss for a healthy lifestyle, and smoking cessation. Smoking leads to a lot of atherosclerosis. So you can imagine the toxins in smoking, in cigarettes, that are circulating throughout your body, and they're harming the arteries because the toxins are floating in the bloodstream and constantly irritating the arterial walls and leading to atherosclerosis. Okay, so dietary, exercise, weight loss, quitting smoking, all come first prior to introducing a cholesterol lowering medication. Okay, so I'm just going to spend a minute on this slide. Not that I'm going to talk about this quote, but it gives me a bit more. I feel like I can add a bit to this slide. So just remember, when you're going through groups of medications, sure, I think it's important to know the prototype drug, and also realize that often many of these groups have the same endings of the drug, the medication. But I don't think it's necessary to know every possible drug in that group. So as we're going through groups, whether it's cholesterol medications, blood pressure medications, heart medications, recognize the prototype. And often once you know the prototype and the effects, the actions, the side effects, anything in that group will be very, very similar. So then just go to the ending of the drug. For example, we're going to talk about a drug called atorvastatin, which is Lipitor. Well, it's a statin. So anything with the ending statin will behave very, very similarly to atorvastatin. So try and understand them as groups, as opposed to trying to remember 10 drugs within a group, because that will become very difficult to remember. Okay, so this slide is a good summary of some antihypertensives that we're going to speak about later. So cardiovascular system. I know we're going to start with cholesterol medications first, but this slide just will help you understand, well, where are these drugs going to work? So in order to lower blood pressure in someone who has hypertension, and we typically use cutoffs for blood pressure, 140 as the systolic, 90 as the diastolic is a cutoff for hypertension. Okay, so beyond 140 or beyond 90 diastolic. So let's just look at this diagram for a minute, because once you understand where medications are starting to work, it's much easier to not only understand the medications, but to remember the medications. So the first part on the left is showing you a diagram of the kidney. Okay, well, we can use medications to drain the body of fluid. And we've spoken about these before. Those will be the diuretics, right? So the thiazide diuretics, the potassium sparing diuretics, maybe even the loop diuretics. So these will drain the body of fluid, and of course also electrolytes. Let's go to the other section. So what about drugs that can affect the blood vessels, the arterioles in particular? We don't typically talk about veins when we're trying to reduce blood pressure. They don't have a lot of muscle in them, so they're not very responsive to vasodilation, to most of the blood pressure medications that we use. So typically when we're talking about vasodilation, we're referring to the arterioles. And I'll mention if we're not. So there's many medications that vasodilate arterioles. So if you vasodilate the arterioles, that's going to make more room for blood in the vascular system, and it's going to lower blood pressure. So there's a group right there, vasodilators. Okay, let's go look at the heart now. What about medications that can slow down the heart rate? Well, if we can slow down the heart rate, that'll reduce cardiac output. And if we reduce cardiac output, that will lower the amount of blood that's flowing into the aorta from the heart, and that will reduce blood pressure as well. So if we think of antihypertensives as, okay, I can act on the kidney to reduce overall plasma volume, so I can work as a diuretic. I can work on the arterioles to vasodilate. Okay, that's going to increase the volume so that they could lower blood pressure. Or I can work on the heart to slow down the heart rate and even reduce contractility, reduce the stroke volume. So there's medications such as beta blockers, for example. There's others as well that we'll come to, that will slow down the heart and will reduce contractility, and they will lower blood pressure. Okay, so there's a number of different groupings. Try to remember it that way, and then it'll make a bit more sense as we get to this part of the module. Okay, so again, let's start with a diagram of where drugs will act for hyperlipidemia or increased cholesterol. So when we're talking about cholesterol, it's not like cholesterol just freely floats through the bloodstream by itself. It gets incorporated in fat globules and different types of them too. So cholesterol is incorporated with lipoproteins. So lipo is fat and proteins is protein. So there's lipoproteins that are made in your liver, and they circulate around the bloodstream, delivering cholesterol, removing cholesterol from different parts of the body, delivering fat or triglycerides to different parts of the body. So these lipoproteins are made in the liver and circulate through the bloodstream. So they're in the vascular space, okay? And there's different fractions of them. So there's different lipoproteins like LDL, low density lipoprotein, HDL, high density lipoprotein, VLDL, very low density lipoprotein. And then there's triglycerides. Okay, so you can measure a triglyceride in the blood. And so when we think of cholesterol, we need to think, well, where is the cholesterol within the bloodstream? And we get measurements of all these lipoproteins. And that is where the cholesterol is circulating in the bloodstream, okay? And we associate, for example, LDL as a lipoprotein with cholesterol, so LDL cholesterol, as causing atherosclerosis. It leads to more blockage of arteries. So we care about that one. We want to see it lowered with medication. HDL, high density lipoprotein, tends to remove cholesterol from plaques, from plaque buildup in arterial walls. So we consider that a good cholesterol. It's actually removing cholesterol and lipids and triglycerides from the plaques that have formed within the arterial wall. So if we were to think of LDL, bad cholesterol. HDL, good cholesterol. VLDL won't be as important. It's definitely not a healthy cholesterol either. And we'll see that with some medications, VLDL is reduced. And triglycerides are just fatty acids. And when they're reduced, there's some health benefits to that as well. Okay? So think of these fatty protein globules floating through your bloodstream that have cholesterol that they're carrying around within them. And that's what we measure in the bloodstream. Okay? So let's look at this image here. So the image is showing you 5 groups, and by far the most common group is going to be in the top right-hand corner, the statins. Okay. Now, before we get to the statins, let's look at the liver. And the liver, it's showing you that there's this circular route here. So LDL, let's start with LDL in the kind of at the 10 o'clock position. So LDL will so that's low density lipoprotein, bad cholesterol, transfers cholesterol to tissues. Okay, so to arterial cells, to tissues throughout the body. HDL removes cholesterol and fatty acids from the tissues. So that's a nice way to remember
that HDL is actually removing cholesterol. LDL is delivering cholesterol. And so is VLDL, by the way, is delivering cholesterol to tissues. So VLDL, LDL, not very healthy to have high levels. HDL, actually quite healthy to have high levels. Okay, and cholesterol is also in high levels and produced in the liver. So we can address the amount of cholesterol in these lipoproteins by trying to block production in the liver. And that's exactly what statins do. So they interfere with an enzyme called HMG-CoA reductase. And what do? They lower the cholesterol production and synthesis in the liver. Okay, so that's a pretty clear concept. What do all those statins do that we've heard about? They lower cholesterol production in the liver. Okay, so let's go to the next slide. Let's go clockwise here. Ezetimibe. Okay, hard one to pronounce. This one, it was felt to be a good idea when it was made by the pharmaceutical companies. It blocks the absorption of cholesterol from the small intestines. Okay, that makes sense. Might work if you eat a lot of cholesterol. The problem with it, and the reason why it's not very effective, and we'll come back to it, is that most of the cholesterol in your body, 90%, is made in your liver already. So now you're dealing with a 10% fraction that is ingested, that you've eaten, that we can use a drug to block it. Now, when you eat cholesterol, it's not like you're eating a bowl of cholesterol. You're eating it within something. Cholesterol typically comes in, as I said, animal fats. It's associated with the fat, right? So if you're blocking cholesterol, it can lead to some gastrointestinal issues because you have a drug that's blocking absorption of cholesterol, so keeping it in the gastrointestinal tract, and we'll come to some of those issues. So not an overly effective drug. Just know what it does. It blocks cholesterol absorption, but because most of our cholesterol is already made in the liver, not very effective. Okay, bile acid binding drugs. So bile acids are made from your liver. And some of it's stored in the gallbladder as bile, and a lot of it is secreted from the liver and goes into your small intestine. And what does bile do? So bile emulsifies fat. So when you're eating bile, when you're eating fatty foods, you get a lot of bile secreted by your gallbladder and by your liver. And it's to mix with the fatty foods, to emulsify them, so that they're easier to absorb. Okay? So if you're, and by the way, when you're secreting bile, which is an emulsifier, you're also secreting cholesterol with that bile. So there's cholesterol within the bile from your liver. Okay, so the idea of these drugs is if I can bind the bile acids that the body is producing in the gastrointestinal tract, and I can stop them from being reabsorbed, because bile acids get reabsorbed after they've been used in the small intestine. They actually get reabsorbed in the distal ileum of your small intestine so that the liver can use it again. Doesn't want to get rid of its bile acid if it can just reabsorb it and use it again for the next ingestion of a fatty meal. Okay, So bile acid binding drugs, they bind the bile, and bile has cholesterol in it. So the idea was to bind the bile that also contains cholesterol within it and stop it from getting reabsorbed, and it would go out in your stool. Okay? So it would increase the excretion of cholesterol in the stool by binding these bile acids that otherwise would have been reabsorbed back to the liver. Okay, so there's another group. The next group are the fibric acid drugs. We don't totally know how these work, but they increase fatty acid breakdown and eliminate triglyceride-rich particles. So it would make sense that these could be targeted towards not only trying to maybe lower cholesterol, but lowering the triglyceride level in your serum. And we'll come back to that. So we don't know exactly how they work, but that's the idea behind them, that they increase fatty acids, the breakdown of fatty acids, and eliminate triglyceride particles. Okay. And lastly, niacin. And again, we don't know all the mechanisms of niacin, but niacin reduces VLDL and LDL levels. Okay, and it acts in your liver. Okay, and those, as mentioned, are two lipoproteins that are harmful and cause atherosclerosis to the vascular system. Okay, so know the 5 groups, and anything that we're going to talk about is going to fit into one of these 5 groups. And I'm going to tell you, by far, the statins are the most common, by far. So understanding the statins and the side effects would be very beneficial. The other ones we'll talk about, understand them, know a bit of detail about them, but I would really concentrate on the statins.
Okay, so here's a typical blood result that you'll get um, for lipids or cholesterol levels. Okay, and this is what is commonly liked to see in terms of the levels. So total cholesterol is less than 200. Okay, HDL cholesterol 35 to 80. So the higher your HDL cholesterol, the better. Okay, and then LDL cholesterol less than 130. Okay, so again, the lower your LDL cholesterol, the better, because that is it's an atherosclerosis. It accelerates atherosclerosis in the blood vessels, leading to blocked arteries. And then triglyceride levels. We want to see your overall triglyceride levels lower than 150, and the lower the better. So what cholesterol makeup would I like to have? I haven't checked my cholesterol in many, many years, but I'd like to have an elevated HDL. I'd like to have a lower LDL and a lower triglycerides. And overall, I'd like to have a low total cholesterol. Okay, so this is typically what we get. Notice that we didn't get VLDL. It's not as important as your LDL levels in terms of the harm that can be done with having elevated LDL levels. Okay, so who do we want to treat with cholesterol lowering or triglyceride lowering medications? Well, patients with proven atherosclerotic heart disease would definitely be a group, because they've been shown to have some benefit from taking these medications. Okay, Patients with diabetes, or patients between the ages of 40 and 75 years old, with LDL levels between 70 and 189. So patients with diabetes are already at high risk for coronary artery disease and developing heart disease, and atherosclerosis. So trying to reduce another risk factor for atherosclerosis, such as lowering cholesterol, such as the cholesterol level, would be beneficial to them. So patients with diabetes as a risk factor, with elevated LDL, but not greater than 130. You'll see that the levels are lower in diabetics, because we want to lower them even more, because they already have another risk factor. So think of the whole, who do we want to treat, is really, as a whole for the person. Do they have hypertension? Are they smokers? Do they have diabetes? Have they had previous cardiac disease? So if they have other risk factors, we're more inclined to treat them to reduce one of the risk factors, such as cholesterol. Okay. The last one, patients with ages 40 through 75 without cardiovascular disease or diabetes, but who have LDL levels 70 to 189 or higher. I mean, if your LDL levels greater than 189, you're still going to treat. So the one group of patients that really don't require treatment, if you have a normal cholesterol level and you have no risk factors, zero, then there's much less evidence that treating a completely asymptomatic person with no proven heart disease is actually beneficial at all. And don't forget, you have to accept the side effects of the drugs that we're going to talk about. Okay, so that would be just encouraging good lifestyle choices, not smoking, regular exercise, good diet, good sleeping hygiene, but not taking a medication if you don't have any risk factors and you don't have any proven heart disease. Okay, so I hope that makes sense. Okay, so what kind of therapeutic lifestyle changes are we talking about? So monitoring blood lipid levels. So when you see the word lipid, think of cholesterol. Okay, lipid is really your HDL, your LDL, your total cholesterol, and your triglycerides. And depending on what your levels are, you may get them checked semi-regularly, maybe once a year or once every 2 years. If you're on active treatment, you may get them checked a bit more frequently. Okay, maintaining optimal weight. So trying to lose weight if your BMI is high is important. Increased weight puts you at risk for hypertension, diabetes, an assortment of other conditions that put you at risk for atherosclerosis. Implementing an exercise plan is a good idea. Reducing total dietary saturated fats and cholesterol. Remember, most of the cholesterol is made in your liver. So people that reduced their dietary saturated fats and cholesterol, they saw a very, very modest change in their blood cholesterol levels, but it's still a healthy dietary change. Okay, increasing soluble fat in the diet. Well, what does that do? Well, soluble fiber, I may have said fat there, but increasing soluble fiber in the diet is, so not only does it prevent constipation, but soluble fiber actually holds cholesterol within it. So you're actually lowering total cholesterol because you're increasing soluble fiber in your diet. So you can see, oat bran, apples, beans, broccoli. So vegetables and fruits, right? Definitely eliminating tobacco. Tobacco is very harmful on your blood vessels, on your arteries, and often leads to atherosclerosis. Alcohol, alcohol can be it's liver toxic, so it can lead to an alcoholic hepatitis, but it's also directly toxic to the heart in large quantities. So it's cardiotoxic. Okay? Limit the intake of dietary fat to less than 30% of overall calories and reducing cholesterol as much as possible. Okay? So that's important. You can still a lot of fats don't necessarily have high levels of cholesterol. It's typically saturated animal fat that have high levels of cholesterol within them. Okay, so this slide is again showing you the five categories that we're going to talk about. Refer back to that diagram at the beginning to see where they're working and how they work. I think just an understanding of how these drugs work will go a long way for you. Not necessarily memorizing nausea for every one of them, okay. So the HMG-CoA reductase inhibitors lowers cholesterol in the liver. Those are the statins. Bile acid resins, what do? So the main one is cholestyramine, by the way. They stop bile acid from being reabsorbed. Bile acid contains cholesterol, so out the way it goes, it gets excreted in your stool. Fibric acids, they lower LDL and VLDL. In some unknown mechanism, we'll get to them. And the main one is gemfibrozol. Okay. Dietary cholesterol inhibitor, ezetimibe. Okay. This blocks cholesterol from being absorbed from the gastrointestinal tract. And lastly, niacin, which works in the liver and lowers certain parts of the cholesterol fractions. And we'll talk about niacin as well. Okay, so remember the different categories, where they kind of fit on that diagram, and I think it'll make more sense. Okay, so let's look at the first group, the statins. Okay, and the prototype for this group now is atorvastatin, which is Lipitor. The first drug in this group in the 90s was lovastatin, which is Mevacor. But I think you can definitely see that the endings are the same for all of them. All of them are going to have the same side effects and the same effects. So really, there's so many of them because different pharmaceutical companies are trying to get, their market share. So by far the most popular right now one currently is atorvastatin. So when would we use atorvastatin or any of these statin drugs? And remember, they lower cholesterol from reducing production in the liver. So hyperlipidemia. So that's usually referring to either a high total cholesterol or a high LDL, a high VLDL, okay? And increased risk for cardiovascular disease, MI, and stroke. So if you're someone who has hypertension and you're a diabetic, you have two risk factors for developing coronary artery disease. So it wouldn't be unreasonable to start a statin medication to reduce your overall risk. Or if you've already had a myocardial infarction or a stroke, starting atorvastatin to reduce atherosclerotic plaques in your arteries and reduce the incidence potentially of further blocked arteries. Okay, so there's the concept, I think it's in the notes on a previous slide, of primary prevention, where you do things to avoid the disease, such as exercising, eating well, not smoking. So you don't actually have the disease yet. That's primary prevention. And there's not a lot of evidence that these drugs are very good at primary prevention, meaning you don't have any disease yet and we're just going to give it to you. But for secondary prevention, meaning you have heart disease, you've had a stroke, you have diabetes and hypertension, and so we want to lower your overall risk. So these are more indicated for secondary prevention. The actions we've already mentioned. They reduce total cholesterol produced by the liver and also LDL. And amazingly, these do raise HDL levels a bit as well. So that's a benefit to them. So the main adverse effects to any of the statins are the same. Okay, so they can be hard on your muscles, your skeletal muscles. And what's the main side effect someone will come back with in a week or two? I have sore, achy muscles after starting atorvastatin. And we check a CK level, which is the muscle enzyme, to see if they have any muscle breakdown. Okay, and if they have, I mean, in rare cases, it can lead to rhabdomyolysis, which is severe muscle breakdown that can potentially put you into renal failure because of all of the muscle breakdown products that are clogging up the kidney nephrons. Okay, and the other one is it can give you a mild hepatitis. So we can check CK for the potential for myositis or myopathy that you can get with statins, and we can check liver function tests before you start the treatment, any treatment with a statin, and also weeks later to make sure that you're not getting a mild hepatitis from these drugs. Okay, and a new one that's come out recently is that over the long term, these put you at risk for diabetes, which is interesting. It's another effect that people are looking at to potentially maybe look at other medications, but these are by far still the most popular. This is the most popular group. So contraindications, well, if you already have, severe hepatic failure, okay, well, we're probably not going to start you on a statin. Pregnancy, no, adjusting cholesterol levels in pregnancy wouldn't be safe because this could get into the fetus. And of course, breastfeeding, same idea. Because remember, cholesterol is needed for your cell membranes to stabilize, right? So it's not like cholesterol is a bad thing. It's only harmful when certain fractions of it, such as LDL and VLDL and triglycerides, are elevated. But you actually need cholesterol to live. It stabilizes the cell membranes of your body. Okay, so responsibility is really encouraging the lifestyle changes, the diet, the exercising, the not smoking, okay? And obtaining baseline lipid studies, which are the cholesterol studies, checking liver function tests before and after starting these drugs, and asking about signs of myopathy, achy muscles, sore muscles. Okay, so you can get myositis or myopathy from these. And in that case, we would check a CK, which is a muscle breakdown enzyme. Okay. This group in general, you avoid grapefruit juice. Okay. Grapefruit juice is going to come up quite a bit because grapefruit juice can inhibit many drugs from breaking down. And actually, in certain cases, it can accelerate some drugs to break down, which alters the levels in the bloodstream. In this case, it can inhibit the breakdown of the statins, which can lead to high levels, which can then increase the chance of myopathy and hepatitis. So I'm going to take advantage of this slide of grapefruit and talk about some drugs. And it may not be in this module, but unfortunately, there's questions that you get asked about grapefruit juice and drugs. And not necessarily only at college, but also on the ATI tests and the NCLEX. They somehow want to know that grapefruit juice and certain drugs should be avoided. So I mentioned that the statin groups, okay? So in general, most of the statin medications should be avoided with grapefruit juice. So we tell people specifically, don't take grapefruit juice anymore. You're taking this statin, such as atorvastatin or lovastatin or simvastatin. Now, unfortunately, there are some statins that you can take with grapefruit juice, but I think as a whole, I would just remember that you shouldn't take grapefruit juice with statins. It would be very difficult to try and tease out which you should and which you shouldn't. Okay. Antihistamines as a group, in particular the second generation antihistamines, fexofenadine, which is Allegra, should be avoided. Coming up later in terms of blood pressure medications, calcium channel blockers should be avoided. And remember, because the reason why we're avoiding grapefruit juice in these drugs is because it alters metabolism of the drugs. Okay, so calcium channel blockers should be avoided, and we'll come to that. Some of the psychiatric medications, such as buspirone, carbamazepine, which is an anti-seizure medication, some of the benzodiazepines, such as diazepam, midazolam, should be avoided, and also some of the SSRIs, okay, such as sertraline, which is the brand name Zoloft. So as a group, yes, some of the psychiatric medications should be avoided. Benzodiazepines, carbamazepine, anti-seizure medication, buspirone, which is a medication for anxiety. Okay. Next, some of the immunosuppressants in the group to remember is cyclosporin and tacrolimus. Those are the calcineurin inhibitors. Okay. So apple juice and those particular two in the calcineurin inhibitor group are to be avoided. Sildenafil, which is Viagra, is to be avoided with grapefruit juice. Some of the HIV medications are avoided with grapefruit juice. Okay, and lastly, amiodarone, which is an antiarrhythmic that we use for cardiac arrhythmias. Okay, so this will come up again and again. So I made a bit of a list here. Would I memorize it now? I don't think so. It's just to make you aware that this is something that you should be aware of certain groups that interact with grapefruit juice. Okay, so let's look at the next group. So bile acid resins or bile acid sequestrants. So what do these do? They bind with bile acids that are coming from your liver, so secreted by the liver and the gallbladder, make their way into the small intestine to combine with fats that you've eaten. And bile acids then emulsify the fats for absorption. So cholestyramine or cholesterol binds with bile acids and stops them from being reabsorbed. And since there's cholesterol, in bile acids, it's going to take some of the cholesterol and the bile acids out into the stool more. So it's actually going to force the liver to make more cholesterol if it wants to maintain its level, since you're drawing and holding more of it in the bowel. Okay, so let's look at the indications first. So look at the first indication. That's got nothing to do with high cholesterol, but we do use it for this. So chronic diarrhea from a multitude of different conditions, such as Crohn's disease. So why would we use this for diarrhea? Well, it's a binding agent. It's a resin. So not only does it bind bile acid, but it's going to also bind and absorb fluid with it. So if you have chronic diarrhea, a binding agent that's going to hold fluid is going to make your stools more solid. Okay. So the next indication, high cholesterol, that's why we're talking about it. Pruritus associated with either liver failure or bile duct obstruction. So when your body spills bile into the bloodstream, or toxins of the liver into the bloodstream, one of the symptoms is itching. It's irritating to the skin to have liver toxins under the skin, and you get pruritus, itchiness. So sometimes cholestyramine is used to make sure that more bile acids aren't reabsorbed, and it helps control pruritus in people with liver failure or bile duct obstruction. Okay? So what's the action of it? Well, it combines with bile acids in the intestine, causing increased bile production, which helps improve cholesterol, which helps remove cholesterol from the body through the feces. Okay, so now if it's binding bile acids, it's also going to bind any fat-soluble vitamins. Because remember, the bile acid has already mixed with fats that you've eaten, and what's in the fats? Fat-soluble vitamins, A, D, E, and K. So you have to be a bit careful, because this particular drug can cause a deficiency in fat-soluble vitamins, because it's stopping them from getting absorbed. So let's look at the adverse effects. They're all going to be gastrointestinal, right? I mean, if you're messing with absorption of bile acid, the reabsorption of it, let's just have a look at the symptoms. So constipation. So this is going to soak up the bile. It's a resin, so it's going to soak up the bile and fluid, and it can lead to constipation if you don't drink enough fluid with it. Okay, bloating, belching, nausea. You shouldn't use this in anybody who has a gastrointestinal obstruction, because you're holding fluid in the bowel. Okay, and that can magnify and worsen someone with a bowel obstruction. Reduction, if you have a reduction, it can reduce your fat-soluble vitamins, because it's taking them out with the bile acids that have been absorbed by this drug. Okay, and it interferes with many drugs. So often you shouldn't take this. You should take this either 1 to 2 hours prior to your other medications, or 3 to 4 hours after your medications. So just think of this drug as, it's not a dangerous drug or anything. It just doesn't, it stops absorption of many medications, and also it inhibits absorption of the fat-soluble vitamins because of how it works. Okay, so the contraindications: someone who has irritable bowel and you're really messing with the fluid shifts and potentially causing constipation if they're not drinking enough. Anyone with any kind of gastrointestinal obstruction, you're potentially making the stools much more bulkier, so that could aggravate a gastrointestinal obstruction. Okay, so it's all gastrointestinal side effects. So nursing responsibilities, checking lipid levels. So these people would have their lipids checked every 3 to 6 months, especially initially. Discussing ongoing lifestyle changes, cigarette smoking, weight loss, exercise, a good diet. Okay, encouraging stool softeners and fiber, and definitely encouraging increased fluid intake with this medication because you will get constipated on it. Okay, and also checking for drug interactions of other drugs that patients are taking, and advice on taking this medication 2 hours before or 3 to 4 hours after, or away from the other medications. Okay, and also it can have a big relief for people that have chronic itching from liver disease. So asking them about that. So a number of other indications which are interesting, plus the elevated cholesterol. Not very popular anymore. Most people didn't like the taste of this. It often came in a powder that you mixed with water and drank it. It 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 just didn't. It wasn't very popular. And then once the statins came out, this was used much less frequently. This can definitely be combined with a statin. So you could be on a statin and cholestyramine. It's just more difficult to prepare this, and so a lot of people didn't want to take it anymore. So this is another group, fibric acids or fibrates. Uh, so gemfibrozole or phenofibric acid. These definitely aren't as popular as the statins. They're still used. They're rarely used though, because they're just not as effective. So the indications, sure, hyperlipidemia, so increased cholesterol, and in particular, increased triglycerides, so elevated triglycerides and elevated LDL. So it's meant to reduce triglycerides and LDL. So the action of this drug is it's felt to inhibit the breakdown of stored fat in fat tissues, which then leads to a decreased production of triglycerides and lipoprotein synthesis, so VLDL and LDL. So if you're inhibiting the breakdown of stored fat, then the fat cells are saying, I don't need more. I don't need VLDL and LDL to deliver more. So the idea is that it reduces VLDL and LDL. The mechanism is a bit unknown, but that is the idea and the theory behind it. Adverse effects, you can get, well, with any of these, gastrointestinal upset. Look, this one, like statins, can cause a bit of a myopathy, and it can cause a bit of a mild hepatitis, just like statins, right? So adding this particular group to a statin to lower cholesterol can be a bit of a risk, because you can increase the chance of myopathy, so muscle aches and muscle breakdown, and also increase the chance of hepatitis, the liver injury. So we frequently will get a CK level and liver function tests at baseline, and then check them after the patient's been started on this medication, and especially if they come in with muscle aches, muscle tenderness, we'll check a CK earlier, or if we notice that they're jaundiced, or if they have malaise or they're nauseated and we think it might be related to liver toxicity, we'll check liver function tests. Okay. And often this drug will be stopped. If it's causing a mild hepatitis or if it's injuring your muscles, the drug will be stopped. The other thing interesting about this drug is it does increase the risk of gallstones. So gallstone production. So there's cholesterol in gallstones. So because it's inhibiting the production of LDL and VLDL, so the bile acid that's being stored, the bile that's being stored in your gallbladder can potentially have higher levels of cholesterol and make you more prone to gallstones. Okay? Now remember, the vast majority of these cholesterol lowering medications, they're not to be given in pregnancy, right? You don't want to be messing with cholesterol levels in a developing fetus. Because as I said before, cholesterol is a very important molecule for cell membrane stability. So most of these are contraindicated in pregnancy. Nursing responsibilities. So there's LFTs, CK, and also ongoing discussions about other lifestyle changes that are important, probably more important than the actual drugs that they take. The lifestyle changes have a bigger impact on their health. Okay, so this slide is just saying ATI chapter 24. And so remember, the biggest bang for your buck is lifestyle changes, right? So that is really what's going to make a big benefit to your cardiovascular health. We know, so think of the risk factors for vascular disease, and that's what we want to prevent. So obesity, hypertension, diabetes, smoking, and hypercholesterolemia. Okay, so and diet. So some are very modifiable, others are not modifiable at all. Right? So cigarette smoking, modifiable. Your gender, so being male or female, not modifiable. Your family history is not modifiable. Your own past medical history is not modifiable. So think of all the modifiable factors. Diabetes, that's a modifiable risk factor. You can control diabetes. Blood pressure, modifiable. You can control hypertension. And hypercholesterolemia, modifiable as well. Okay, so always think of your non-modifiable and your modifiable risk factors. Okay, so ezetimibe. So again, this drug is not very popular because remember, most of your cholesterol is made in your liver. What's this drug doing? It's trying to inhibit cholesterol absorption by the gastrointestinal tract. So it blocks absorption of gastrointestinal cholesterol from bile acids or from your diet. Okay, so it will have a very, very modest effect of lowering your total cholesterol, lowering LDL a bit, especially if you've changed your diet and gone onto a low cholesterol diet. Okay, so action inhibits absorption of bile cholesterol and your dietary cholesterol that you've eaten, causing a decrease in blood cholesterol levels. Adverse effects, usually well tolerated. You can get a bit of diarrhea from this because whenever you inhibit absorption of something, you're actually blocking cholesterol absorption. So you can get a bit of fatty stools, which is steatorrhea, because cholesterol lives with fat. So if you're blocking cholesterol, you're going to get some fat in your stools. So that's greasy stools, okay? And this can also lower your your fat soluble vitamins A, D, E, and K. Definitely not a medication you would take with pregnancy either. And not often combined with statins. So statins have really taken over as the group for quite a few years now. Okay, so again, it comes down to what's the best advice you can give someone? It's the lifestyle modifications. Monitoring of CK and LFTs. The biggest one for that is definitely the statins. You can still get a mild myopathy, a muscle aches, muscle breakdown from this, and also a mild hepatitis. So so the monitoring for this would come down to CK and liver function tests, and also being aware that this can drain fat soluble vitamins A, D, E, and K. Okay, so it's kind of interesting that a lot of these drugs that we talk about, it's like okay, monitor CK, monitor liver function tests. Because they can injure the muscle. People can come in with muscle symptoms, and you can get a mild hepatitis from them. So monitor LFTs. Again, the big one to remember, the group to remember, are the statins. They're by far the most important. Okay. So here's another cholesterol-lowering medication, niacin, which happens to be vitamin B3. It's used in much higher doses to have its cholesterol-lowering effect. But if you look at the indications, yes, we can use it for elevated lipids, elevated cholesterol. We can use it for pancreatitis with people that have elevated triglyceride levels. Okay, so this particular drug, its action, it really reduces triglycerides, and it can reduce LDL. We already have a very good drug that reduces LDL called statins. But if we really want to reduce someone's triglyceride level, we would still use niacin. Okay? And the most common reason for reducing someone's triglyceride levels is when you have elevated triglycerides, it can cause pancreatitis, which is a pretty nasty condition causing severe upper abdominal pain that radiates to the back. And it's almost like the pancreas is the pancreas gets very irritated and inflamed from high triglyceride levels. So what are the most common causes of pancreatitis? Well, definitely alcohol can lead to pancreatitis. A gallstone that's stuck in the pancreas, causing the pancreatic juices to auto-digest the pancreas, another common cause. And the one after that, as a cause of pancreatitis, is elevated triglycerides. Okay, so niacin still hangs around because of that. The main side effect of this is you can get intense flushing. Okay, so facial flushing, body flushing. You can really feel this vasodilation effect of the skin. Okay. Now, okay, so there's that liver toxicity and a myopathy if it's combined with statins. So they're all starting to sound the same in terms of that. But the flushing really stands out with niacin. Okay. Again, we would really try to avoid this in pregnancy or if you had liver disease because there's liver toxicity. Is it toxic to pregnant women? Not toxic, but we always try to avoid medication. So this is category C. Okay. So often people will come back once they've been started on niacin to reduce their triglyceride levels, and they'll complain of the intense flushing. And the advice that they're given is to take an aspirin 30 minutes, an hour before the dose of niacin. And what that does is really offset the intense flushing that they get. Okay. This is given with meals to try and reduce gastrointestinal side effects. We do check liver function tests with this medication. Not everyone can tolerate this medication because of the flushing. And we also suggest a high fluid intake because some people are prone to gout flare-ups with this medication. And if you're drinking a lot of fluid and you're flushing uric acid out the kidneys, you're less prone to gout. The big one to remember for this is the intense flushing and the fact that it's treatable by giving a dose of aspirin prior to taking this medication. So this next drug called mipomersen, this would be very rarely used. This would be in a lipid clinic, like a specialty clinic, and the indication is for familial hypercholesterolemia. So extremely high cholesterol levels that are inherited genetically through family. So it's not just for your, moderately elevated cholesterol. It's definitely people that have very strong family histories of early onset of atherosclerosis, and they have this condition called familial hypercholesterolemia. Now, this is not a medication to be taken lightly. You have to go to a lipid clinic. You have to sign waivers for this form because of its toxicity. It's very liver toxic. So I think just knowing this medication and knowing what it's for, certainly not used compared to the statins, which are used extremely frequently. And lastly, there's another medication that they mention in ATI, a monoclonal antibody. It ends in MAD, so it's a monoclonal antibody, and they made this monoclonal antibody alirocumab. They always have special names, to the low-density lipoprotein, so the LDL receptor. So this again would be in a specialized lipid clinic. Okay, I don't think you would see too many other people on this in the general public. Remember, monoclonal antibodies are just proteins, so this would be injectable. Okay, it wouldn't be a medication that you'd be going home with and taking on a daily basis. It would be an injectable medication. Okay, so let's start talking about hypertension. So elevated blood pressure in the arteries, and as I'm sure you've studied already, there's systolic hypertension and diastolic hypertension. Okay, so and we've chosen numbers of 140 as the systolic, over 90 as the diastolic numbers that define hypertension. So you could have just systolic hypertension and your blood pressure is 160 or 170 on 70. Or you could have diastolic hypertension where your diastolic number is over 90. So let's say it's 135 on 110. So that'd be diastolic hypertension, or both. Both are elevated. Okay, so we've chosen a number of 140 over 90. And why did we choose that number? Because studies over decades have shown that consistently elevated blood pressures above those numbers put you at risk for strokes. So whether they're ischemic strokes because of atherosclerosis that have formed in the blood vessels going to the brain, or they're hemorrhagic strokes because of the high blood pressure. They also put you at risk for cardiovascular disease from atherosclerosis. So you get atherosclerosis in your coronary arteries that feed your heart, and they gradually get blocked uh, from the plaque formation that's occurring, and you develop angina. And finally, if the plaque ruptures and blocks the coronary artery, you get a myocardial infarction. Okay, so, and in the rest of the body, hypertension is hard on all of the arteries. So it'll be hard. It'll cause atherosclerosis in the blood vessels going to your legs, to your kidneys. Hypertension in general is hard on your kidneys, right? So chronic hypertension is one of the risk factors leading to renal failure, because the kidney is constantly seeing this elevated blood pressure, and it's damaging to the nephrons. So hypertension is it's a system-wide problem with the arterial vessels, and it's damaging them by causing atherosclerosis, and it also damages the end organs that these blood vessels are going to. So whether it's the brain, the heart, the kidneys, it's damaging to all of them, in the form of strokes with the brain, angina and heart attacks with the heart, and gradual renal failure with the kidneys. Okay, so think of atherosclerosis as a system-wide problem. If you have atherosclerosis in the heart, in the form of coronary artery disease, you likely have atherosclerosis in other arteries of the body as well. Okay, so let's look at this slide in terms of where will drugs work so that we can reduce blood pressure and control hypertension. Okay, so let's start in the top, at the top, and go clockwise. Alpha 2 agonists. Well, that's not a terribly popular group, but we will talk about one called clonidine. And basically, by stimulating this alpha 2 agonist, it's the strange one that's in the brain. It decreases sympathetic impulses and reduces norepinephrine in the bloodstream. So it leads to a slowing of the heart and vasodilation of the arterioles because you have less norepinephrine. Not a very popular group because, again, these receptors are in the brain, so you get you get potential side effects that are CNS, and we'll talk about those. Okay. Alpha 1 blockers. So alpha 1 receptors are on blood vessels, and if you can block the alpha 1 receptors with alpha 1 blockers, you'll block norepinephrine from vasoconstricting and tightening the arterioles, which leads to hypertension. That's what can cause hypertension. So if you block the vasoconstriction of the norepinephrine with alpha 1 blockers, you'll get vasodilation and a reduction in blood pressure. And we'll talk about those. There's also direct vasodilators. There's drugs that directly act on the muscle or on certain channels in blood vessels, and they cause the smooth muscle to relax, and you get vasodilation. Okay. There's a group called calcium channel blockers that we'll talk about. And calcium channel blockers are interesting. They vasodilate. So some of them will vasodilate, and some of them will work on the heart and slow it down. And we'll talk about them. Okay, so calcium channel blockers, they block calcium ions into the smooth muscle, leading to vasodilation. Just like, so there's a whole bunch of them there that are causing vasodilation. Alpha 1 blockers, actually alpha 2 blockers as well, direct vasodilators, calcium channel blockers, angiotensin receptor blockers, so the ARBs, because angiotensin 2 is such a powerful vasoconstrictor, if you can block it with an angiotensin receptor blocker, you will get vasodilation. Same with ACE inhibitors, right? You're getting less angiotensin 2, so you will get less vasoconstriction with ACE inhibitors as well, okay? Diuretics, we've spoken about, increased urine output and decreased overall fluid volume in the plasma will reduce blood pressure. And beta blockers. So what do beta blockers do? They slow down the heart and they reduce contractility of the heart, and that reduces cardiac output, leading to less blood leaving the heart, which will then cause a reduction in blood pressure. Okay, so we're only going to talk about 3 ways to reduce blood pressure. We're either going to vasodilate the arteries, we're going to slow down the heart and stop it from beating so hard, or we're going to get rid of some fluid out through the kidneys. Okay, so try and group it a bit so that it makes a bit of sense as we go forward. Okay, so this next slide is again, you know what, if you understand the slide, then the blood pressure pills will make sense. So what's blood pressure being determined by? So, well, how much blood volume do you have in your vascular compartment? So the first box. And how can we alter that? Well, with fluid adjustments. So by using diuretics, we can drain fluid off of the overall blood volume. And by blocking aldosterone, which in effect are ACE inhibitors, ARBs, or spironolactone, they block, they end up either blocking the secretion of aldosterone, such as in ARBs and in ACE inhibitors, or they directly block aldosterone from working at the kidney and cause a diuretic effect. Okay, so overall blood volume is affected by diuretics and by blocking aldosterone. Okay, what about peripheral vascular resistance? Well, for the most part, peripheral vascular resistance is going to be determined by the arterioles, so the smaller blood vessels that can vasoconstrict really, really tight and increase blood pressure, or they can vasodilate and open and allow blood through them, and that'll lower blood pressure. So the medications that can vasodilate the arterioles are typically the ones that will reduce peripheral resistance. So ACE inhibitors, well, they reduce production of angiotensin 2, which works on the blood vessels. So if we reduce angiotensin 2, that's going to vasodilate. ARBs, well, they block angiotensin 2. They'll help vasodilation. Direct-acting vasodilators, they'll vasodilate. Alpha-1 blockers that we'll talk about, they cause vasodilation. And alpha-2 blockers, like clonidine, also cause vasodilation by reducing the sympathetic output from the brain, and also thereby also reducing norepinephrine in the circulation. So they will also vasodilate. Calcium channel blockers, they also work on the blood vessels, and they block calcium entry into the smooth muscle, and the arterioles vasodilate. Okay, and the other way we can, so if we open up the blood vessels and we reduce peripheral resistance, we reduce blood pressure. What about cardiac output? Okay, so drugs that can reduce either the heart rate or the stroke volume will reduce cardiac output. And those are typically beta blockers, because beta blockers reduce heart rate and reduce contractility, which is stroke volume. And also, as you'll see, there's calcium channel blockers that not only work on the blood vessels, but they also work on the heart, very similar to beta blockers. They reduce heart rate and they reduce contractility. Okay, so this is what we're looking at. So if you can think of drugs again, if you can box them into one of these two columns, you'll be able to categorize them a bit more. So if I was looking at blood volume box, I would be thinking of diuretics and drugs that block aldosterone from either being secreted, such as ACE inhibitors and ARBs, or drugs such as spironolactone that block aldosterone from actually working. Okay, peripheral resistance, all the drugs that cause vasodilation, and there's a whole bunch of groups of them. Just go to the slide above, you'll see there's a whole bunch of groups that do that. Reduce cardiac output, okay, beta blockers and some calcium channel blockers that we'll get to. Okay. Okay, so cardiac rules. These are general cardiac rules to go by. So changing positions slowly. Definitely if you're on antihypertensives or cardiac medications that can affect your blood pressure, changing position slowly is always a good idea, because you can get rapid shifts in blood pressure. You can get orthostatic changes in blood pressure by getting up too quickly. Okay, and that's how people get dizzy, they get hypotensive, and then they fall. Considering to hold a medication if the blood pressure is less than 90/60. Considering to hold the medication if the blood pressure is less than 60 or greater than 100. Always advising patients never to stop an antihypertensive or a cardiac medication abruptly. These medications are typically either trying to control hypertension or control angina. So if they're stopped abruptly, what happens? You'll get rebound hypertension, or you'll aggravate anginal symptoms. And then daily weights, so as opposed to weekly weights. So daily weights, there's only one thing that you can put on 2 pounds a day or 5 pounds a week, and that's going to be fluid, right? So if we have someone in hospital with congestive heart failure, and we're using diuretics to take off the fluid, we're going to get frequent weights, typically daily, to see how much fluid we're removing from the patient per day, right? So, and significant weight gains or losses, 2 pounds a day or 5 pounds a week, that's usually the maximum that someone should be gaining or losing. And people with congestive heart failure are told, if you're at home and you notice that you're gaining 2 pounds of fluid a day, or 5 pounds per week, you need to call us so we can adjust your diuretic or your other medications, right? And the same goes for if we're adjusting medications and you're losing a lot more than 2 pounds a day or 5 pounds a week, then you may be getting too much medication. So good general rules to remember in terms of antihypertensive and cardiac medications. Okay, so these words will come up as we're talking about different drugs, and it's just describing. So inotropy is just telling you the contractility of the heart. chronotropy is telling you about the heart rate, and dromatropy is telling you about how is the electricity being conducted in the nerves of the heart. Okay, so when we give a drug, we can say, well, it's a positive inotrope. It's a positive chronotrope, meaning it will increase contractility, it will increase heart rate, and if it's a positive dromotrope, it'll increase electrical conduction, making it more efficient in the heart. So for the most part, drugs are typically all of one, so they're all positive or they're all negative. So for example, epinephrine. So an injection of epinephrine, well, it's going to increase contractility, meaning increase inotropia. It's definitely going to increase your heart rate, increase chronotropia, and increase the efficiency of conduction in the heart, in the nerves, increase dromotropy, right? There are some drugs, such as beta blockers. Okay, they reduce contractility, so they're negative inotropes. They reduce chronotropy. They're negative they reduce heart rate, sorry, so they're negative chronotropes. And they reduce the conduction of impulses in the heart, so they're negative dromotropes. There's one in particular that we haven't spoken about yet, a drug called digoxin that happens to be a positive inotrope, increases contractility. Oh, but look at the difference. It's a negative chronotrope. It slows down the heart rate and it slows down electrical conduction in the heart. Okay, so just know these three terms and what they mean, because you'll hear about them in different with different medications, whether it's a positive inotrope or a positive chronotrope. Yeah, so good terms to know. Okay, so this slide is on a concept called first dose phenomenon, and this usually relates to antihypertensives or cardiac medications, and the concept is the first dose can cause a sudden and severe drop in blood pressure. I mean, which makes sense. I mean, it's the first time that the body is seeing this medication that's either causing vasodilation or something that it hasn't become accustomed to at all. So you can have sudden drops in blood pressure. Probably the most common group of medications to do this are the alpha-1 blockers, such as prazosin or terazosin. So alpha-1 antagonists, so remember they block the alpha-1 receptor on the arterioles. So you get vasodilation. This particular group of medications, we invariably start low and go slow. So we start at a low dose, typically at bedtime, just in case their blood pressure does drop significantly. And we increase the dose slowly as weeks go by so that they can tolerate it. So what else about this first dose phenomenon? So syncope just means that you fainted, and then you returned, your level of consciousness returned to baseline again. So you got up too fast, you had a syncopal event, you collapsed, and then within seconds or a minute, you woke up again. Okay. So, and that is really why this particular group of medications, the alpha-1 antagonists, are given at bedtime to make sure this first dose phenomenon doesn't cause someone to fall during the day. And then if they seem to tolerate it okay, and they don't have significant drops in blood pressure, the medication can be switched to daytime dosing instead of bedtime. Your blood pressure tends to be significantly higher through the day, especially upon awakening. You can imagine awakening can be a stressful time. You're getting ready for the day, your sympathetic system is turning on. And nighttime tends to be a more relaxing time, and people's blood pressure often drop through the night. So antihypertensives are preferentially given through the day. Okay. I think this is a repetition of a slide, so I don't have too much to say on this slide anymore. It was in the upper part. It was in the earlier part of the module.
Okay, so let's look at some drug classes for hypertension. And like many conditions that you'll come across, there's often first line, second line, and even third line medications that are used for that particular condition. Just to help group the evidence of which ones are most effective, which ones have less side effects. So it's a combination of many things that put them into first line and second line. So if we go to the first line medications for hypertension, you'll see that ACE inhibitors and angiotensin receptor blockers are there. And they, except for some differences in side effects, they're very, very similar. ACE inhibitors is the one that can give you this, the tickle in the back of your throat, this persistent cough. The angiotensin receptor blockers tend not to do that, but they can both give you significant angioedema, tongue swelling, mouth, lip swelling, and they're both prone to causing hyperkalemia in someone with severe renal failure. So we'll talk about those. So calcium channel blockers. There's calcium channel blockers can be a very effective group. So some calcium channel blockers purely vasodilate the arterioles, and we've already spoken about the concept that when you vasodilate the arterioles, you make the lumen of the arterioles wider. That lowers the blood pressure. So there's some that do that by blocking calcium channels. There's also calcium channel blockers that also vasodilate, but they also have an effect on the heart by slowing down the heart, so reducing chronotropy and reducing inotropy. So they kind of behave like a beta blocker as well. So we'll come to those as well. And then there's the thiazide diuretic group that we've spoken about before. Hydrochlorothiazide being the main one in this group. And they work at the distal convoluted tubule. They drain potassium, sodium, many of your electrolytes, plus of course they take fluid down the nephron as well. Okay, so they're not as powerful as loop diuretics, and they're very commonly used in hypertension. Okay, so what about some of the second line medications? So alpha-1 adrenergic blockers we'll talk about. So when you block the alpha-1 receptor on arterioles, you stop norepinephrine or epinephrine from vasoconstricting, making those blood vessels very vasoconstricted. So this allows the blood vessel to dilate. Okay, they don't have any effect on the heart. They just act by vasodilating the arterioles. And so we'll talk about terazosin and prazosin as alpha-1 blockers. Alpha-2 blockers, that's going to be that unusual and very old medication. Clonidine. There's also another one in that group called methyl-dopa. And when they stimulate the alpha-2 receptor, it reduces sympathetic flow in your body, in your system, and that reduces norepinephrine in the bloodstream. Beta blockers such as atenolol, metoprolol, bisoprolol, propranolol. We'll talk about some of the prototypes for this. So they block the beta-1 receptor in the heart, and by blocking the beta-1 receptor, they stop the sympathetic stimulation to the heart, and that reduces heart rate and reduces inotropy. So reduced chronotropy, reduced inotropy, and if we wanted to add the third one, reduced dromotropy. Some of them are selective, meaning they're much more, they block the beta-1 receptor more than the beta-2 receptor in the lungs, so they're cardioselective. And some are non-selective, such as propranolol, and they just block the beta-1 and the beta-2 receptor. We'll talk about direct-acting vasodilators. So these are drugs that directly act on the blood vessels. Most of them act on their direct arterial vasodilators. So we're going to talk about a drug called nitroprusside, or hydralazine is another one that we'll talk about, that act directly on the blood vessels to vasodilate them. We'll talk briefly about a renin inhibitor called aliskiren. It's in the same pathway as your ACE inhibitor and your angiotensin receptor blocker. It just works more at the beginning of the pathway, since it's a direct renin inhibitor. So we'll talk about that as well. But remember, it's going to have similar effects and side effects to the ACE inhibitors and the ARBs, since it's blocking the same pathway. Peripherally acting adrenergic neuron blockers. I think we'll leave that one. I'm not sure which one that's referring to, but I'm sure we'll cover the important ones. Okay, so this slide is distinguishing effectiveness of blood pressure medications based on the black population versus the non-black population. And we know through studies that black people tend not to be as responsive to ACE inhibitors and angiotensin receptor blockers, and as well they have the potential for more of the severe side effects, such as angioedema. So you'll see that the first three lines here, they're basically identical in terms of the drugs that are used for the non-black population versus the black population, except the ACE inhibitors and ARBs are taken out of the black population due to the reduced effectiveness and more side effects. Okay, so if we take the first line, age 60 or greater without diabetes or chronic kidney disease, well, really any of those would be totally appropriate. Okay, and in the black population, any of them except the ACE inhibitors and the ARBs, just due to the fact of lack of effectiveness and more side effects. And that goes on for the next two as well. So all ages with diabetes, no chronic kidney disease. Still, it's the same drugs. But let's look at the bottom one. All ages with chronic kidney disease. So ACE inhibitors or ARBs are recommended. And that's because with mild kidney disease, or even moderate kidney disease, ACE inhibitors or ARBs have been shown to be renal protective, meaning if you have a mildly elevated creatinine, or if you're starting to show some proteinuria, you're leaking protein in your urine, these groups of medications have been shown to slow down the progression of kidney disease. Okay? The other group that we often use these two medications in, and you'll see it in brackets on the lower. So all ages with chronic kidney disease present, and often we use them in diabetics, so with diabetes. And so diabetes leads to kidney damage, leads to renal compromise and renal failure. And the studies have shown that using an ACE inhibitor or an ARB in the setting of diabetes and some renal failure slows down the progression of the renal failure. Okay, so they are used in particular in diabetics with chronic kidney disease.
Okay, so let's start with prazosin. So this is an alpha-1 blocker. Where's alpha-1? On the arterioles, on the blood vessels. So by blocking the alpha-1s, you don't allow norepinephrine or epinephrine to vasoconstrict, and you get vasodilation. So it's indicated in hypertension. So this can be used as a treatment for hypertension. It also blocks the alpha receptor at in the prostatic valve or the lower bladder in males, and by blocking that receptor, the alpha-1 receptor, you get relaxation of the prostatic valve and improvement in urinary flow in males with BPH. Raynaud's disease is a vasoconstrictive disease of the small arterioles of the fingers and toes, where your fingers turn blue and then sometimes white and then go back to normal. And typically it's affected by cold. It's much more common in women. And I mean, the main treatment for it is to, not let your hands get cold. If it's impacted significantly by cold weather, so proper gloves, proper mittens, hand warmers. But sometimes in severe cases, we'll use an alpha-1 blocker to try and stop the vasoconstriction and keep the small arterioles vasodilated in the digits. Okay, so the actions have already been mentioned. It's competitive alpha-1 receptor blocker. More so in the arterioles than anywhere else. And also relaxes the prostatic valve because there's alpha-1 receptors there. So the adverse effects, also dizziness for sure. So especially dizziness upon getting up, because your blood pressure, your body can't respond when you get up fast by vasoconstricting and maintaining your blood pressure. So when you stand up too quickly, you'll feel dizzy. Because of the vasodilation from these drugs, your heart is you're going to get reflex tachycardia. Okay, so your heart's going to say, well, I'm not sure why the blood vessels are vasodilated and the pressure's going down, so I'm just going to speed up. So you get a temporary reflex tachycardia for the first days to a week. Drowsiness can occur, fatigue. Again, think of it as a lowering of the blood pressure, potentially less blood flow to the brain, so some CNS effects there. Orthostatic hypotension, so orthostatic blood pressure changes when you stand up. And the first dose phenomenon that we've already spoken about, where you can have significant drops in blood pressure, unpredictably severe, so started at bedtime. Contraindications. Elderly isn't really a contraindication. It's just a take care. Be very careful in the elderly because you can make their blood pressure drop. And if they fall and they break their hip or a head injury, it can be the beginning of the end. So just got to be careful in the elderly. Coronary artery disease we try to avoid because by themselves they're going to cause a reflex tachycardia and speed the heart up. So if you had severe angina, you wouldn't want to cause the heart to speed up, even if it's for days or a week. Definitely low blood pressure. We wouldn't give this medication. It'll lower it even more. And angina, it's the same thing as coronary artery disease. So the reflex tachycardia is what you're trying to avoid. So not giving it to someone with angina by itself. Nursing responsibilities, yeah, to monitor the blood pressure and heart rate for sure. Hypotensive concerns, giving them information about you need to be careful when you stand up too quickly. You should start this medication at bedtime and to see the response. And for someone who has hypertension and BPH, so it's going to be a male, so a male with hypertension and some difficulty urinating because of an enlarged prostate, these medications can help two conditions, the hypertension and the BPH, right? So it can be beneficial in someone with both of those conditions. So give it nighttime as initial dose, then switch to daytime. And being very careful with altering your position from sitting down or lying to standing up position.
Okay, so beta adrenergic blockers, they're definitely used as antihypertensives. They're also used for other conditions like such as angina, or after having had a myocardial infarction, we'll use them. But we're just going to concentrate on how you can use them for hypertension. So again, when you use these drugs, no matter what you're using them for, they're broken up into two main classes. We'll talk about the bottom one, but that's not that important for this talk. So cardioselective, meaning they're beta-1 receptor antagonists mainly. And the main one for this, metoprolol, is a very common one. Atenolol. So they have less effect on the beta-2 receptor in the lung. When we go and look at the non-selective beta blockers, they will affect both the beta-1 receptor and the beta-2 receptor in the heart and lungs. And these can put people at risk for shortness of breath, wheezing, if they have an underlying lung condition, such as COPD, asthma, pulmonary fibrosis. So conditions where the lung is already compromised, and now you're blocking the beta-2 receptor. Okay. Now, there's also blockers of both alpha and beta, but we don't need to get into those. So, carvedilol, labetalol, they're beta blockers, but they have some alpha blocking effect as well. But that's not important. Okay, the importance is to understand cardioselective versus non-selective. Okay, so these drugs, you've heard this before, they slow down the heart rate. Okay, they're beta blockers, so they reduce chronotropy. They reduce the contractility of the heart as well. So they're negative inotropes. And by reducing the chronotropy and the inotropy, they reduce blood pressure. They reduce the work of the heart as well, and that's why they're used in angina. But for this, they help reduce blood pressure by these effects. Okay, so propranolol. So propranolol, beta blocker, it's non-selective. It's an old beta blocker. So the older a drug is, the more indications it tends to gather over time. Okay, so, and I can tell you, we really don't use propranolol very much in hypertension anymore. You could certainly use it, but we just don't, because there's many other beta blockers, and we prefer to use ones that are cardio-selective, so beta-1 selective. But it wouldn't be a fault to use it. We just don't. So the indications, sure, you could use it in hypertension, angina, okay, because beta blockers. So think of it as a group. Except for the fact of splitting them between beta 1 and beta 2 and which ones have that effect. Just think of them as a group as a whole, because they all have the same side effects. So, and mainly indications too. So angina, could use it in angina. In fast arrhythmias, such as atrial fibrillation, we can use beta blockers to slow them down, because they slow down the heart. They're negative chronotropes. Now, propranolol, because it's been around for a long time, was discovered that it has some effect if taken as prevention, as preventative medication for migraine headaches. So you could use any beta blocker. It's just that because propranolol has been around for so long, that's the one that we became accustomed to using. For people that get recurrent migraine headaches, they can stay on propranolol, and they would need to take it every day. So it's not as an acute treatment, it's as a preventative treatment. So MI prophylaxis. So we can use this to reduce the workload of the heart. So we can use it after an MI to reduce the workload of the heart. Reduce reflex tachycardia. So say you give someone an alpha-1 blocker, such as prazosin, and that vasodilates the peripheral arterioles, and they get this reflex tachycardia, they get dizzy, and we can't go up on the dose, even though their blood pressure, say, is still elevated. We can't keep on going up on the alpha-1 antagonist dose, because they're going to get more dizzy and orthostatic symptoms. So sometimes we'll just keep it at a low dose and add a beta blocker, which slows down the heart and helps lower the blood pressure. Sometimes we'll use these in combination at lower doses, different medications, that is, so that you don't get all the side effects of one medication in particular. Okay. So propranolol, non-selective beta adrenergic antagonist, blocks the beta 1s and the beta 2s. Adverse effects. So definitely one of the most common things to remember with beta blockers as a whole is they cause fatigue. They slow people down. People often come back a week later, 10 days later, and say, I'm exhausted, I'm tired, I can't stay on this medication. Okay, so fatigue is a really big side effect with beta blockers. Bradycardia, we've spoken about. Hypertension, sure, they can lower blood pressure too much. Reduce contractility, and we've spoken about. Slash cardiac output, that's the negative inotrope. And because they block beta 2 receptors, you can cause some wheezing and some flare-ups of asthma and COPD. Okay. So when would we avoid beta blockers? Well, if your vital signs are already low, say you have a low heart rate and a low blood pressure, well, we're not going to add a beta blocker. Heart block, meaning your heart is already beating at a slow rate, less than 60, we're not going to add a beta blocker. Heart failure gets to be a confusing one, because sometimes we do use beta blockers in heart failure. But let's just say just moderate heart failure. We would use other medications, because remember, these are negative inotropes. They're going to reduce cardiac output. and you wouldn't want that in heart failure. Okay, and of course COPD, asthma, COPD. We wouldn't use this particular one. So under nursing responsibilities, yeah, always remembering the cardiac rules. Beta blockers can mask shock. So say you were sick and you had your blood pressure was gradually going down because you were in, say, an accident. Well, beta blockers will block it a bit, will not show it as clearly. They'll block your tachycardia. You won't get the tachycardia that you normally get with shock if you're on a beta blocker. Okay? And in diabetics, as your sugar potentially goes to a dangerously low level, and the sympathetic system is trying to warn you, if you're on a beta blocker, it can't warn you as effectively because the beta blocker is blocking the sympathetic warning signal. Okay? Caution in patients with depression, for sure. Remember, this causes severe and profound fatigue. It can also give people nightmares. So just be careful in people with depression and beta blockers. Okay, so remember, I kind of mentioned propranolol sometimes, specifically to the wheezing and the shortness of breath and asthma, because it's a non-selective beta blockers. But in a lot of it, I just mentioned the word beta blocker because they all have very similar effects, contraindications, and they have the same side effects. So don't try and memorize each beta blocker. Just remember it. Remember one, and remember the effects and side effects and responsibilities, because it's going to be very similar to all of them.
Okay, so let's look at the next drug, metoprolol, another beta blocker. And this is a beta 1 specific beta blocker, or cardioselective beta blocker. And you'll see other ones listed. I think it's more important to remember that metoprolol is a cardioselective beta 1 antagonist. Okay, there's many beta blockers. There's no way of remembering them all. So what do we use metoprolol for? So we can use it for hypertension because of its effects on the heart. We can use it for rapid rhythms, such as atrial fibrillation, which is a rapid rhythm coming from the atria, the upper chambers. We can use it for angina because it reduces the workload of the heart. It reduces contractility and it reduces the heart rate. So less work that the heart is doing. Therefore, in angina, it's usually a supply and demand issue, right? So the supply of blood is reduced because you have a coronary artery occlusion. So you have less blood supply feeding the heart. So if you can reduce the workload of the heart, then you don't need as much blood supply. So beta blockers can definitely help in angina. Symptomatic heart failure. So here's where it gets confusing. You'll see in one page that beta blockers are contraindicated in heart failure, and in another page they're used in heart failure. So it starts to get a bit confusing. So let's just spend a bit of time on this. So in someone who has significant heart failure, so severe heart failure, the heart is not pumping well. They have backup of fluid into the lungs. They have poor contractility and decreased cardiac output from the heart. Okay, so what's the sympathetic system going to do? It doesn't really care that the heart's not that the heart's pumping less. What it really cares about is that it's sensing decreased cardiac output and it's sensing a reduction in cerebral blood flow. That's what the body cares about. So it's going to activate the sympathetic system to make the heart work harder. So beat faster, contract harder, and vasoconstrict the blood vessels to maintain perfusion to the brain. That's what the body cares about. But that's okay in the short term, but in the long term, that's more damaging to the heart. So beat harder with the sympathetic system, beat faster with the sympathetic system is not a good, it's not going to come to a good conclusion in the long run. So it's been shown that beta blockers that reduce the heart rate, reduce contractility, even in the setting of heart failure, can be beneficial to stop the body from making the heart work so hard. Okay, so that's why we use it in severe heart failure. Okay, so what's the action? Well, it's beta-1 selective receptor blocker. Reduces heart rate, reduces contractility, and reduces dromatropy or electrical conduction in the heart. Adverse effects will be the same as any beta blocker. This is just a reminder, you always taper, you always gradually reduce any cardiac medication or blood pressure medication. You typically reduce them, but in particular beta blockers for sure, you would gradually reduce them. You wouldn't suddenly stop someone. Okay? Contraindications, it'll be the same as any beta blocker. And nursing responsibility to monitor the vital signs, to be aware of when not to administer beta blockers, such as a heart rate less than 60, a blood pressure less than 90. Always being aware of never allowing someone or always advising someone to taper beta blockers and to follow the cardiac rules. Okay. Okay, so remember we were going to talk about some direct vasodilators. So here's a couple that are direct vasodilators. So hydralazine and nitroprusside. So nitroprusside is really an intensive care type drug. It's an IV drug that we use very carefully when someone has a hypertensive crisis. We want to bring their blood pressure down in a very controlled setting, and we could use something like nitroprusside. Okay, hydralazine can be given IV, but it also comes orally. Okay, so it's not only for hypertensive crisis. You'll see that hydralazine is indicated for gestational hypertension. So someone who develops hypertension while pregnant, hydralazine is one of the choices that are used. Because both of these are very powerful vasodilators, they reduce the afterload of the heart. They significantly reduce the workload of the heart because they're reducing systemic blood pressure, right? So for someone who has severe hypertension, hypertensive crisis, we can control the blood pressure very closely and reduce it with these medications, hydralazine or nitroprusside. I mentioned gestational hypertension for hydralazine. What about heart failure? Well, we'll sometimes use one of these. We use it as an afterload reducer because it reduces the blood pressure, so it reduces the afterload of the left ventricle, right? So that it can pump blood more easily forward into the aorta. Okay? These are not commonly used drugs. As I said, nitroprusside is really an ICU type drug. Hydralazine is heavily used more in gestational hypertension compared to the general population that has typical high blood pressure. Okay, and they can certainly be used in severe hypertensive crisis where someone has a very high blood pressure And we're starting to see that they have end organ damage, meaning you have a pressure of 250 on 150 and your brain isn't working properly, such as you're confused, you're delirious, or your kidneys are showing signs of distress with increased creatinine, or you're having chest pain, anginal chest pain, because your heart can't pump against such high pressures. So we could use this when we see a severe hypertension with end organ damage. Okay, so the actions: peripheral vasodilation relaxes the smooth muscle in the arterioles and reduces blood pressure and peripheral vascular resistance by doing that. Okay, it will increase the heart rate because the heart's going to say, whoa, what's going on? The blood pressure's dropping, you're vasodilating, I'm going to increase the heart rate. So it has a reflex tachycardia from hydralazine. Adverse effects, well, there's the reflex tachycardia because you've vasodilated. Definitely hypotension, so we would watch these people pretty closely. Headache, well, headache is because you're vasodilating, so you can get these pounding headaches because you're also vasodilating the arterioles in the brain, so you can get these pulsating headaches. Flushing, well, you're vasodilating the vessels in the skin. Edema, peripheral edema, you're vasodilating the vessels in the lower legs, so you can get some peripheral edema. The one that really stands out here is that you can get lupus-like syndrome from hydralazine. So you can get this rash across your face from hydralazine, this what's called a malar rash, this facial rash that's classic for lupus, but you can get it from hydralazine. So what about the contraindications? Well, if you're already tachycardic, this drug will likely make you more tachycardic because it's vasodilating. It's going to make the heart beat faster. In heart failure, I wouldn't say all the time. It just depends on the circumstances because remember, this is an afterload reducing drug. So sometimes we would use it in heart failure. I don't want to say that would be a never there, so I'm not trying to confuse you. I think I would probably just leave that one alone because it is used in heart failure sometimes. In lupus, yeah, it might flare up the rash of lupus, and you can get a lupus-like syndrome, so we would avoid it in that. Cardiovascular disease, sure. So you can imagine if we're vasodilating and we're making the heart beat faster because it's trying to keep up with this lowering blood pressure, we could cause some trouble with the tachycardia, right? Angina, chest pain, and so. Rheumatic fever. Well, in rheumatic fever, if you've had rheumatic fever, you're typically left with valve diseases of the mitral and the aortic valves. So they're either really scarred down and blood doesn't flow through them very well, so they're stenotic, or blood leaks backwards into the chamber where it was pumped from, and that's regurgitation. So if you're messing with vasodilation with this drug, you could really get someone with rheumatic fever or rheumatic heart disease in trouble because they have valvular disease. Okay. I mean, I can imagine it'd be hard to remember all these contraindications, and I think if you just understand that this is a vasodilator, it's a direct vasodilator used in hypertensive crisis, gestational hypertension, I think you'd be doing well. And if you remember a couple of the side effects. Now let's go to the nursing responsibilities. So for sure, vital signs, right? This is going to really lower your blood pressure. Daily weights isn't a bad idea. We're messing with blood pressure. We want to know input and output of fluids. You can use beta blockers to treat the reflex tachycardia. So say someone's blood pressure didn't come down with hydralazine, and you know that it's a peripheral vasodilator, well, a beta blocker would work very well with that if you wanted to continue to lower the blood pressure, because beta blockers slow down the heart and decrease contractility, so they would work together very well. One vasodilates, one slows down the heart. Okay. And remember, this can cause a lupus-like rash. Okay, I think you've probably had more information than you need on hydralazine. As I said, I mentioned a couple of things that are important in terms of gestational hypertension, hypertensive crisis, and it's a direct vasodilator. Okay, and the unusual adverse effect is definitely the lupus-like rash. Okay, so nitroprusside. So as mentioned, this is really an ICU/ER type drug, and this is really to get someone's severe hypertension down urgently. Okay, so this is someone who has a hypertensive crisis, so severe hypertension plus end organ damage. So the hypertension is leading to heart failure, renal failure, neurological symptoms because it's so high. And this drug dilates the arteries and the veins. Okay, so it definitely reduces vascular resistance in the arterial system, which of course leads to lower blood pressure. Okay, so the adverse effects: hypotension for sure, IV drug. This is a drug that would be titrated very slowly. So you'd increase it a bit with the IV, you'd check the blood pressure. You'd increase it a bit, you would check the blood pressure. And if it got too low, you would back off. You would reduce the drug. Okay. Reflex tachycardia, same idea as hydralazine. Headache, you'll get a pulsating headache because it's vasodilating the arterioles in the brain as well. Dizziness, that's a blood pressure issue. The blood pressure is lowering. Flushing of the skin, yep, because the blood vessels are dilating in the skin as well. And cyanide poisoning, we'll come to that, because when you are maintained on a nitroprusside drip, typically 1 to 2 days, you can develop cyanide toxicity. So people don't usually stay on this for very long. Contraindications, hypotension for sure. And the other one, elevated ICP. Sure. So if you're vasodilating and someone already has elevated intracranial pressure, you're going to make it worse, because you're vasodilating the vessels in the brain. And if the ICP is already elevated, you're going to be taking up more space in the brain by vasodilating all these vessels. Okay, so that would not be a drug that we would use with say, head trauma and decreased level of consciousness. Okay, under nursing responsibility, so it's an IV-only drug. It's titrated, as mentioned, to the vital signs, so we monitor the vital signs. It needs constant blood pressure monitoring. And you can get cyanide or thiocyanate poisoning. And levels can be checked, but typically this is a 1 to 2 day drug. You're not going to be maintained on this drug for a long time. Okay? And I think we'll stop there. That's enough. That's definitely enough information on this drug. Okay, well, eplerenone. So very similar to spironolactone, right? You can basically consider them. They're in the same group. So if you know what spironolactone does, then you're going to know what eplerenone does. And typically, so we can use this in hypertension. We have a lot of other options, but we could use this in hypertension. And so how do these work? How does spironolactone work? Well, it blocks aldosterone receptors in the kidney, and it stops sodium and water from being reabsorbed, which is what aldosterone wants to do. So it stops that, and at the same time, potassium is blocked from being secreted. So it stays in the serum. So you can run into the same problems with hyperkalemia with the eplerenone. Okay, just as you can with spironolactone. So if you look at the adverse effects, hyperkalemia, hyponatremia because it's draining potassium with the water. And you can get a diminished libido, as you can with spironolactone. One of the reasons why this came out is because it tends to not cause as much gynecomastia as, if you recall, with spironolactone. Men could develop small breasts with spironolactone, and eplerenone doesn't tend to do that. If you look at the contraindications, yeah, definitely. If you have a high potassium already, you'd avoid this. Pregnancy, breastfeeding, and severe renal failure. If you ever take a drug that one of the side effects is high potassium, it's always going to say, do not use with renal failure, because you're dependent on your kidneys to filter out the high potassium. So taking a drug that can cause high potassium and you have renal failure is always a bad idea. So we would monitor vital signs because it'll drop the blood pressure. We would monitor fluid input and output because it's in effect a type of diuretic, right? It's stopping sodium and water from being reabsorbed, and the body's keeping potassium. So we're going to monitor potassium levels for sure. And we may need to adjust someone's diet to have a lower potassium diet due to the fact that this drug will maintain potassium levels in the serum, just like spironolactone. Okay, so it can be used in hypertension, not very often, and it can be used in heart failure, just like spironolactone can be used in heart failure as a diuretic that spares potassium. You don't lose your potassium. Okay, so for example, I could use, or in hospitals, they would use furosemide, which is a loop diuretic, and you could use eplerenone or spironolactone. So furosemide, you lose your electrolytes, you lose your potassium. Spironolactone or eplerenone, you keep your potassium. So they can be used in combination, right? So this will spare the potassium from being lost. So sometimes there's mixtures of diuretics in people with severe heart failure. Okay, so next drug, this is definitely an uncommon drug. There's already too many ACE inhibitors and ARBs on the market, so this inhibits the same pathway. It doesn't have any clear advantage at all. So, and because it's newer, they're always more expensive, right? So, yeah. But we'll talk about it briefly since it inhibits a slightly different part of the pathway of the RAS pathway. So aliskiren, it's marketed as for blood pressure. So it's an antihypertensive. And it directly binds and inhibits renin from stimulating the angiotensin system. So it works at a very early part in the renin angiotensin aldosterone system. But really it's going to have the same effect as an ACE inhibitor or an ARB, right? It's going to finally, in the end, reduce production of angiotensin 2 and reduce aldosterone secretion from the adrenal gland. So if we look at the adverse effects, they're going to be like ACE inhibitors, right? Because you're getting those, you're inhibiting the same pathway, so you have potential to get angioedema. And angioedema, if you ever get a chance, look up a picture of ACE inhibitor angioedema. It's really dramatic. Swollen tongue, swollen lips, a real potential for airway obstruction. And it can happen at any point in the use of an ACE inhibitor or aliskiren. So definitely a concerning side effect at any point. Cough, yeah, just like an ACE inhibitor, you can get this persisting, nagging cough. That can take weeks to go away after you've stopped the drug, whether it's aliskiren or an ACE inhibitor. You're prone to hyperkalemia. Why? Well, you've reduced aldosterone secretion, and aldosterone was really secreting potassium into the kidney and reabsorbing sodium. So if you've inhibited aldosterone secretion, you have the potential to give hyperkalemia, just like an ACE inhibitor, or an ARB, by the way. And hypotension, sure, it's an antihypertensive by inhibiting the RAS system, so you could lower the blood pressure beyond what you wanted to. Contraindications, so pregnancy, definitely someone with hyperkalemia already. The respiratory disorders and the diabetes, this drug is extremely uncommon. I don't think this will be a big part of your knowledge base for aliskiren, so I can't really comment on the respiratory disorders and the diabetes mellitus. So nursing responsibilities, vital signs, yep. Checking potassium because it inhibits the RAS system. Watching for signs of angioedema, which is those swollen lips, swollen airway, swollen tongue. And definitely we wouldn't use these in combination with an ACE inhibitor or an ARB, because we could really cause hyperkalemia then, okay? So because it inhibits the same pathway. So I think that's really all you would need for this particular drug. Not a common drug. Okay, so let's move on to the next drug, and this is an alpha-2 agonist. So this is that receptor in the brain that works the opposite of the sympathetic system. So typically, if you stimulate the sympathetic system, you're an alpha agonist, such as an alpha-1 agonist. You're going to increase the blood pressure. But alpha-2 agonists or alpha-2 receptors do the opposite. They cause vasodilation when they're stimulated. Okay, so clonidine is an alpha-2 agonist. So it can be used and was originally used for hypertension. It still can be, but not very commonly. In actual fact, it's used more commonly for withdrawal of alcohol and withdrawal of opioids, narcotics. Okay, so people trying to withdraw from those, we can use clonidine to try and make it easier to withdraw from narcotics or alcohol. It can also be used for the flushing associated with menopause. So that makes sense a bit. You're stimulating the alpha-2 receptors. You're causing some vasodilation, not the vasoconstriction and vasodilation you can get with menopause. So it can be helpful with that. And then it was discovered that it could be used in attention deficit disorder in children and Tourette's syndrome, which is these constant tics and verbal outbursts that children can get. It got the indication for Tourette syndrome. So you can see with all these indications that this drug's been around for a long time, probably the 1950s or 1960s. And because it works on the brainstem and it works in the brain on the alpha-2 receptors, a lot of the side effects, unfortunately, are CNS related, and we're, as a prescriber using this medication, most are not very keen on getting CNS side effects, and the patient's not very keen on getting CNS side effects. Okay, so look at the actions. It's an alpha-2 agonist, decreases sympathetic outflow, resulting in decreased stimulation of the alpha and beta cells in the heart and peripheral vascular system. Okay, so less norepinephrine will give you vasoconstriction. Less norepinephrine at the heart, bradycardia, reduced contractility. So you can see how it could act as an antihypertensive. So the adverse side effects: orthostatic hypotension, sure, you're vasodilating. Bradycardia, yeah, less norepinephrine because of this drug. Now look at the side effects coming from the brain because it's acting in the brain. Depression, insomnia, very sedating drug. Okay, so you're reducing the sympathetic nervous system. You're playing in the brain, and so you're getting brain side effects. And then dry mouth, again, you've turned off the sympathetic system. So it's messing with the nerves. Think when you see clonidine, the side effects are often low blood pressure, low heart rate, and then CNS side effects. Okay, because of where it's acting. Contraindications: you certainly wouldn't stop this drug abruptly. Again, because of rebound hypertension. You'd suddenly have a surge of norepinephrine in the bloodstream, and that would cause rebound hypertension. Nursing responsibilities, so vital signs for sure. This is an antihypertensive that can also cause bradycardia. So monitoring blood pressure. Carefully withdrawing from this medication if the intention is to stop it. One of the reasons why we use less and less of this is that this is a very toxic drug. So if grandma or grandpa is taking clonidine and one of their grandchildren get into it, it can literally take 1 or 2 pills to potentially kill them. So because of the potential toxicity, it's used less and less. And a lot of care needs to be taken because it has sedative effects. So because of all of these reasons, it's just been used less and less. I would say it's used more in narcotic withdrawal and alcohol withdrawal than anything else now. Okay, so this next slide is really just to give you an idea of there's a whole bunch of different options for a condition called hypertensive emergency, where your blood pressure has gotten to a point where it's led to injury to the organs that the blood vessels are feeding, whether it's the heart, the kidneys, the brain. So it's an uncontrolled hypertensive crisis, right? So I don't think the intention is to memorize these drugs at all. Maybe look at the class more than the drugs. Okay, calcium channel blockers, ACE inhibitors. We've spoken about beta adrenergic antagonists. Dopamine agonists I wouldn't spend any time on. Hydralazine we spoke about as a direct vasodilator. Labetalol, again, it's another beta blocker. Nicardipine is a calcium channel blocker. We'll talk about those. Nitroprusside we spoke about in the setting of a hypertensive crisis. It's a direct vasodilator. And phentolamine is an alpha-1 antagonist, so it blocks norepinephrine from getting to the alpha-1 receptors and causes vasodilation. So I would just look at the classes and say, okay, I recognize some of these classes. I haven't done some of them yet, but I don't think the intention is for you to memorize this slide or memorize the onset. Just understand that there's many different types of drugs in different groups that's used for hypertensive crisis. Okay, this is the last slide. So I'm not going to comment too much on Hawthorne, but I do see that in this slide it mentions cardiac glycosides, and I don't think we've spoken about those yet. So the one that you're really going to spend some time on, and the only one, is one called digoxin. And digoxin is an older drug, and we still use it for certain conditions. And I think you'll need I just wanted to mention it here because we will be talking about it and its effects, and how we use it for the cardiovascular system. Okay, so that's the end of this. That's the end of this slide. I hope that helped.